Hello, everyone, and welcome to the Health Equity Q&A, The Gaps in Cancer Care, virtual panel discussion. My name is Laura Williams, and I'm a member of the U.S. Medical Organization at Bristol Myers Squibb, located in Central New Jersey. It is my pleasure to serve as the moderator for today's event. On behalf of Bristol Myers Squibb and our leadership, we would like to thank you for joining us today for what we hope you will find not only informative, but you'll be able to identify solutions to take back to your institutions to drive change. In the healthcare industry, we've been on a mission to improve health equity for many years, continuously building on what we've learned and expand our tools to tackle these issues in a meaningful and productive way. The COVID-19 pandemic has unfortunately exposed and exacerbated health and healthcare inequities for underserved communities nationwide. And we recognize that they occur across many different elements, such as race, ethnicity, socioeconomic status, age, location, gender, disability status, and sexual orientation. Unfortunately, cancer care is not immune to these issues. And with the awakening of the world to health equity challenges, this has shed a light on the imbalances in a way underserved and vulnerable communities are receiving and accessing care. For some patients and their families, the impact from these inequities could be crippling, and for others, it could mean total devastation. That's why we're here. Today, we'll hear firsthand experiences from patients and a healthcare practitioner who happens to have deep and rich expertise in the subject of health equity. It is a true pleasure to be joined by Dr. Karen Wingfield, Executive Director at Meharry Vanderbilt Alliance, Ingram Professor of Cancer Research, Department of Radiation Oncology, as well as Woody Brokenburr and Amy Wu, two cancer survivors and advocates who will share their experiences navigating the complex healthcare system and the unmet needs and challenges that currently exist. Woody and Amy are also part of Survivorship Today. For those who aren't familiar, Survivorship Today is an initiative led by Bristol Myers Squibb that illustrates the challenges which cancer survivors experience as they live much longer than ever before due to the breakthroughs in cancer research. Over the next hour and a half, we will discuss a range of topics from access to care, systemic racial and cultural biases, and health disparities in the approach to cancer survivorship. We will also share examples how you, as healthcare providers, may address these core challenges related to health inequities and disparities, which significantly impacts cancer care for certain groups. During the last half of our program, we will offer you a chance to ask our panelists questions. You can submit your question throughout our discussion simply by typing in the chat box to the right-hand side of your screen, where I will then ask your question when we get to the Q&A portion of the program. Before we begin, I would like to give the panelists each an opportunity to introduce themselves.
I'm Woody Brokenburr. I am in Agoura Hills, California, and I'm a childhood survivor of osteosarcoma, or bone cancer. I was diagnosed at the age of 10 years old, and I've been a cancer survivor for 60 years. It's kind of hard to believe that. Equal care is very important to me, and also quality of life issues. Thank you, Laura.
That's excellent. Thank you so much, Woody. Hi, Amy. I'll transition to you next. Can you also tell us a little bit about yourself?
Hi, thank you so much. I'm so happy to be here today. My name is Amy Wu. I am a breast cancer survivor. I was diagnosed, I am actually joining you today from Hudson Valley, New York, in upstate New York. I was diagnosed in 2013 with aggressive DCIS. I was treated then as well with a lumpectomy and also with radiation. I am a ABC, which is American-born Chinese, and first generation American, and I am also an advocate. Since I was diagnosed and treated, I've been very active in trying to be part of the outreach, especially to the Asian and Asian American community and to underserved communities throughout the United States. So thank you for having me here today.
No, thank you. Thank you, Amy and Woody. Very important work you both are doing. Last but definitely not least, Dr. Wingfield, can you please also share a little bit about yourself?
Yes, well, excuse me. Thank you, Laura. And I want to thank Bristol Myers Squibb for putting on this really important panel, which allows the patient voice to say everything that needs to be said. You've already mentioned that I'm a radiation oncologist. I actually specialize in the treatment of breast cancer and blood cancers like lymphoma, leukemia, multiple myeloma. And those have been my specialty areas for many, many years. And one of the things that's been interesting for me is to watch the way that my career has changed and grown and developed. And in fact, Bristol Myers Squibb was a part of that. I'm a biochemist, and so my PhD is actually in biochemistry. And Bristol Myers Squibb helped to fund part of my dissertation work through their academic medicine fellowship program. And I tell you, one of the things that struck me even way back then in training was the fact that not everyone has the same access to healthcare, to well-being. And that began a lifelong change in my career trajectory, really focused on understanding what some of the barriers might be, figuring out ways that we can actually meet people where they are, doing community engagement, and then truly implementing sustainable change. Really important. So I am excited about today's conversation. Again, I want to thank you so much for having me.
Thank you, Dr. Wingfield. And very much important part of this program is hearing all the great work in which you have done. So thank you again, everyone, for being here today. I think this is going to be a fantastic discussion. It's going to be a lot of great information to share and hopefully, again, allow our audience to take back some of these pearls and tips to their clinical practice. All right. So with that being said, there's a lot to discuss. So we'll go ahead and get started. Woody, I'm going to go ahead and start with you because you have a very interesting experience, one that's rich in history. And so with that being said, you were diagnosed during the 1960s, during a very important historical era of segregation. And so if you can, please share with us what that was like, how had that impact your treatment experience, as well as anything that experience has led itself to impact the way you look at cancer today.
Thank you, Laura. When I had cancer, my family and I knew very little about cancer. As a matter of fact, I was very athletic and I developed a lump on my left thigh. And of course, my parents thought it was perhaps a sports injury, so they treated it with one of the local pain applications. And when it did virtually nothing, they became alarmed and took me to our family doctor. And at that time, they had to get sense after some heat lamp treatments, which was not a good thing. Decided to do a biopsy, and I was diagnosed with osteosarcoma, which resulted in the amputation of my left leg above the knee. At that time, really, there was not much from a treatment. It was either surgery, which I had. And so the doctors decided that they would amputate my leg really high, and that would give me the better chance for survival. So it turned out that they were correct. So I have lived over close to 60 years more after having lost my leg to osteosarcoma. One of the very interesting things is that when I was in the hospital was my first time interacting really with the healthcare in my city. And it was a segregated hospital. We were relegated to the basement of the hospital, and it was called the colored ward. And this was in Central Florida. So just think I'm this young kid receiving, moderate or substandard care almost, and just floors above me is where the premium care was being delivered. When I think about the experience, I come from a family of 10 children. So my parents were working, and then they had all these kids. And I just felt so very alone in my experience in the hospital because they couldn't spend a lot of that time with me. One part of my inspiration for becoming an advocate was because my community rose up to support my family and I during that time. And I just decided I made an intention that I would live the remainder of my life serving, giving back as a volunteer. And that's what I've done. One of the things that I find in volunteering is that, I've learned so much about cancer, but I've also met such wonderful people along the way. So thank you.
No, this is great. I mean, advocacy work is definitely important during such a critical diagnosis such as cancer. So thank you for allowing others to kind of learn from your experience. I have some other points I'm going to touch on later that you brought up, but I would like to transition to Dr. Wingfield because there's an element about your experience from the 1960s that I'm interested to see from Dr. Wingfield's perspective. Dr. Wingfield, do you see any prevalence today among patients of color in the way in which cancer care is delivered? And if so, are you able to see cancer institutions taking action to address some of these barriers or challenges of racism?
Yeah, Laura, it's a great question. And I think Woody's example of the fact that he had to be treated in the colored wards, right? And people don't realize that segregation was not that long ago, right? I went to school in the South. I got my MD and my PhD in the South, and there were still segregated wards in the 70s, right? So, the challenge is really highlighting for those who have chosen to close their eyes to the fact that this nation was born and developed and grown on the backs of slaves, and that those vestiges still exist today. So while there may not be wards that are labeled colored, there's still some of that same tenet that exists. And we call that structural racism, right? So we know that there are so many barriers to healthcare that are built into the system, that are built into the ways that our societies are even developed. And again, if you're not directly impacted by it, you might not notice that. For instance, redlining, which was really popular in the 1930s, which was a law that was on the books that prevented real estate and mortgage brokers from lending to Black families in particular areas. It essentially forced segregation. Do you know that those laws still exist on the books? They're still there today. Redlining still exists today. And we know that housing impacts, that your zip code actually impacts your healthcare greater than anything else, greater than your DNA, right? Where you live matters. Location matters. Doesn't matter if it's urban or rural. Where you live matters. And when we have forced segregation that still exists today, that impacts our ability to educate, right? I mean, you think about all of the early childhood education, the impact that one's tax bracket and the tax assessments that happen on the homes has on the education system. These are things that are built into the system now that actually prevent people from getting the care that they need because education matters. Woody talked about the fact that his family wasn't aware of cancer. Now, there's been a lot of awareness that's come, in the past, 60 years for everybody. I mean, we've grown by leaps and bounds in terms of understanding cancer, right? We had the War on Cancer that was established, and we've been going gangbusters ever since. But that lack of knowledge is still a huge barrier to people getting care, as is whether or not they have insurance. Now, insurance is just a card. It's just one part of access. And I say this over and over again because I practiced in Boston for over 10 years. And I tell you, we had Romney Care before there was Obamacare, right? So people mislabel the Affordable Care Act as Obamacare, but I'm saying that because, again, people make the assumption that the Affordable Care Act is just about Democrats. No, we had a Republican governor who established universal health care coverage, and our uninsured rate was less than 4%. But it still didn't change the fact that people didn't always have access. So how do people feel when they walk through the doors? While you might not have a sign that says colored sitting there, how do people feel when they walk through the door? Do they feel disenfranchised or do they feel welcome? And these are the sorts of structural barriers, these things that we as providers, as institutions need to really think about, because we know that Blacks in particular have the greatest risk of dying of cancer than any other racial or ethnic group, despite the fact that some of those cancers, they have the same incidence. So there's a lot of work to be done that still resonates in the story that Woody told.
Wow. Well, thank you for giving us a good glimpse and a good foundation on how this still is prevalent today. With that being said, Woody also mentioned something else, Dr. Wingfield, and I'd like to stick with you for this next question. He was sharing with us some of the personal barriers and challenges. And so with him bringing that up, I really would like to get your perspective on helping us understand the impact on patient care, cancer care, that is, when it comes to these personal barriers and challenges, whether it's location, it's language, whether it's employment, salary versus hourly wage. If you could just share what your perspective and work has been around that space, that would be great.
Yeah, this is the social determinants of health, right? SDOH, so social determinants of health. We are hearing it over and over and over again in the news, especially since COVID, right? COVID-19 has opened people's eyes to the fact that healthcare does not happen in a vacuum, that most of health and well-being actually happens outside of the healthcare system. It's the social context that people find themselves in. You mentioned housing. Right, think about the fact that individuals with COVID-19 who may be overcrowded in their housing space, right? We see this a lot with immigrant families where they may have, relatives that come over or friends and family that stay with them. There might be 20 people living in a home, right? They've had higher risk of exposure of COVID, and they then probably had higher risk of actually having complications because, particularly if they're immigrant, they may not have access to healthcare. There are all of these social things that matter. What about food and food insecurity? There's some suggestions that about 33% of cancer patients have some degree of food insecurity. Yet, is that a question that oncologists and providers even ask? Do you have food? Are there any things that might impact your care? Well, I tell you, nutrition is one of them. How about that, right? Whether or not people have transportation. Transportation is the #1 barrier to healthcare. Again, doesn't matter whether it's rural or urban, but that is obviously impacted by the social determinants of health. So again, the challenge comes, who's responsible then for helping people meet their needs? And so it's my estimation that we all have to work together, whether it be clinicians, providers, advocates, family. Woody talked about the fact that his community helped his family, but he also made it very clear that he was very isolated. He was very alone in his journey in the hospital because his family wasn't able to be there. And we've got to remember that not everyone has a salary job or has the ability to take, family medical leave so that they can be there for their friends and family. And it doesn't mean that they don't care. It doesn't mean that, patients are non-compliant because they don't show up to appointments. People have lives, and the way that our current country is set up, unfortunately, it does disproportionately impact those who may not have the social standing or may not have the ability to take time off from work to actually get the care that they need.
Couldn't have said it better, Dr. Wingfield. Treat the patient, not just the disease, because there's many factors that go into caring for that patient besides just their cancer. So
Absolutely.
at this point, I'd like to bring Amy into the discussion. Hi, Amy.
How are you, Laura?
My question for you, very good. My question for you is, as an Asian American woman, you also have some experiences and challenges around the time of your diagnosis. And it was really historically rooted in some of the Asian cultural sensitivities and specifically around the stigma of cancer. So if you can you help us understand what that was like around the time of your diagnosis and share with us what that experience was and anything that you find to be relevant to share?
Yeah, so my story is that I was diagnosed when I was actually working overseas. I mentioned earlier, I was born and raised in this country. I'm a Chinese American, but I was actually working in Hong Kong at the time and teaching. So I was at the very tail end of finishing my work contract there, and I discovered a lump on my left breast. And at first I was wondering if this was just something I had never noticed before about my body, but it never left. So I feel lucky in the sense that it was in a place that was really noticeable. And I was in my, I was only 37 at the time, so in my 30s. And I went to, I advocated for getting actually a biopsy and getting an ultrasound. And I also didn't speak the local language. So I was told at the time that, oh, you're only in your 30s, this could be fibroids, but I'm an introvert by nature, but I just had an intuition that I had to push for myself. And I said, no, this is not normal. and everything. So I found this voice. It turned out that it was breast cancer. I'm a swimmer. I think I eat pretty healthy. I mean, I love chocolate though and some other things, but I have no family history of breast cancer at all on both my parents' side. So it was a real shock to me. I mean, I actually, to this day, sometimes when people say you're a cancer survivor and I hear the word cancer, I'm a little bit still like, yeah, I had cancer. I'm a cancer survivor. So I felt like the experience overall was a lonely one, and I can still say is a lonely one because culturally, Asian Americans and Asians don't talk much about what could be construed as negative. So in this case, obviously cancer. So when I was diagnosed and treated, there was, I had my family members there and they loved me and I loved them, but nobody mentioned the word cancer. Everything was very technical, meaning I only had maybe one or two family members who said, oh, let's talk about doctor appointments. Let's talk about the calendaring of the appointments. And having dinner together, nobody ever mentioned why I'm not working anymore and why I'm at home now. So I found myself emotionally and more kind of mentally very in a lonely place. So how I overcame those challenges was that I'm a writer and actually a journalist by profession. And I used my writing as a way to share my own feelings. So I ended up blogging about my experiences with the local English language paper. Was pretty outspoken about that. I actually documented my treatment and took photos with my iPhone and shared that. And why did I do that? It was partially for myself because I felt like I was empowered and I had an outlet to share my story. And I wanted this untold story to be told. But I also wanted to share with other young women, in their 30s at the time, 20s, that this could happen to you. You could be swimming and healthy and eating and healthy and have a really good social life and a job. And for some reason, you end up being diagnosed with cancer as well. So there was two parts of it. So fast forward, I still feel that there are moments of isolation because the broad brush is that my family pretty much says that, okay, this is in the rear view mirror. Why are you still talking about this sometimes? But I think I've moved forward and continue to share my story because I think that it can make a difference in maybe somebody's life.
Wow, thank you very much, Amy. I mean, you said quite a few things that I'm going to touch on in a little bit, but one thing is definitely be your own advocate and talk about it. Don't keep it to yourself. Sometimes the power is in connecting with your community of others to be able to bring you to some level of understanding of what you're currently experiencing. So thank you for sharing and being so candid. At this point, I'm going to transition back to you, Dr. Wingfield, mainly because I would like to hear the physician experience. And perhaps, you may have some education or perhaps some information to share on helping us understand the unique cultural nuances, in particular around the challenges physicians face when trying to help culturally diverse and underserved patient populations access the care that they need.
Well, first of all, I want to tell Amy that chocolate is a health food. We all know that. And so I describe it regularly to myself and to patients. Thank you. Thank you, Amy, so much for sharing your story. Oh, my goodness. So both you and Woody are phenomenal. I just must say thank you, because there's so many nuances in everyone's story, right? And it highlights the fact that as clinicians, we need to see who's sitting in front of us. And we need to be very careful not to espouse the stereotypes, right? So while Amy did mention that, her community, they do tend to be closed. We see that in other communities as well. Let me tell you, I'm sure Woody can talk a little bit about African-American community, not talking about the C word, right? That oftentimes things get brushed under the rug, or we find out that Uncle so-and-so went into the hospital and died. And we're like, well, what happened? We don't even know our family histories. So part of what I want today to talk about is the fact that it's important for providers to see who's sitting in front of them. And this goes beyond kind of implicit bias. We hear that term, and people like roll their eyes, and I'm not biased, and I treat everybody equally. And I tell people, please do not treat people equally. Treat people equitably. Treat them the way that they need. Because again, and Amy and Woody, both educated individuals, Amy knew to advocate for herself. There may have been assumptions, people make assumptions. I've had mentees come to me who are Asian, of Asian descent, who say, everybody thinks I'm good at math. I'm not good at math, and I don't want to be good at math. And it makes me feel bad that I'm not good at math because this is an expectation. Those discrepancies and those disparities can go both ways. So it's really important for as clinicians and providers to really have, and I like this term, culture humility. People talk about cultural competency, and in some ways that means that there's something that you can learn and be an expert at. And there's not. Like, we cannot be an expert in terms of understanding the person in front of me. They're their best advocate. They're the one who knows themselves the best. So what we need to do as providers is come to every situation with cultural humility. And that means asking questions. If Amy, for instance, came into my office by myself, I'd be like, hey, how are you doing today? How are you feeling? Is there anybody else you'd like to have, as part of this conversation? And COVID has really helped us with this, right? You can pick up the phone. How about that? And even if somebody's not physically present in the room, for somebody to be able to pick up the phone or to do a telehealth or telemedicine visit allows family members who may otherwise want to be there but cannot because of their social circumstance to be present, right? Not making assumptions about her sexual orientation. Who lives at home with you? Not like, oh, are you married? Who's your husband, right? Right? Or Woody, who's your wife? Asking open-ended questions that allow people to disclose, to say that, I'm a provider, I'm coming at you, you're a brand new person to me, I want to know who you are in every aspect of your life. And asking those questions in such a way that says, I don't know you, I'm humble, I accept you the way that you are, and to not dismiss, because Amy brought up something very important, right? And actually, Woody, you talked about this too, right? People weren't quite sure what was going on with your diagnosis. And this happens over and over again, right? But Amy had the sense to say, wait, this is not right. This is something that's different. And in empowering patients to say, you know your body the best. And even if it's a matter of like, you know what? I know that this is something new for you. Why don't we go ahead and get an ultrasound, and that way we can know for sure, right? But she knew to do that. There are other people who may not. And I think this is why it's really important for providers to really come with cultural humility, figure out where people are, and really help people navigate their way through the system as well.
There's 3 things that I walked away with. Ask open-ended questions, digital capabilities, leverage them more. Thanks to COVID, we've seen that they could bring a sense of community even when they can't be there physically. And then treat people equitably. I think that is not hard to ask, but you can't treat everyone equally because everyone has their special, unique circumstance that may impact the way in which ultimately the outcomes for that patient may actually play out. All right, so we're going to switch the subject a little bit. Thank you, Dr. Winfield, for that. At this point, Woody, I'm going to go back to you, and we're going to talk about advocacy, the importance of it. And I know you've dedicated a lot of your life to advocacy for all the years in which you've lived and survived with your cancer survivorship journey. And with that being said, it would be helpful for you to share with us, from your perspective, what have you experienced around racial biases and challenges that you see either yourself and or others going through today?
Thank you. Actually, there are a number of things that come to mind. One, the first would probably be medical mistrust in our community. When you kind of think about how we were experimented on as Black people, that still resonates today. As you were talking, one of the things that I found really important in my own journey is I had a woman who's a person of color as my doctor for like the last 30 years. And, I had this comfort level with her because I knew she was going to take care of me. And she had become a part of my family and vice versa. And so when she decided to retire, I had to seek out another medical professional who was not a person of color, who came highly recommended. But there was no connection. I just kind of felt he was going through the motions, and I wasn't getting the kind of care that I had come to to appreciate for those 30 years that I had a person of color. One thing that I'm doing is with our local medical center, and we did a health equity presentation. And some of the discussions that we had relative to clinical trials that were going on is that, some of the people of color didn't have the transportation, and that was something that Dr. Wakefield talked about. They couldn't get to the center to participate in those trials. So, and sometimes there's kind of like these assumptions. I had a procedure a couple of months ago where they had to insert an IV. And so this technician sort of poked me in both arms and couldn't get a vein. And so she says to me, "Your skin is very tough." And I was like, what? There's no difference between black or white skin, right? So it was sort of like one of those subtle racial digs. So I think it's, sometimes it's tiring when you're going through this over and over in your treatments and in life. So it kind of makes me think about there's a concept that Dr. David Williamson, the Harvard School of Public Health, talk about is weathering. And he gave the example of that if you have a piece of concrete and if there's just like a drip drip on it, there's no effect. But if there's a constant drip, it starts to break down that concrete. So think about that in the life of a person of color with racism. You're encountering these slights all through your life. It's going to somehow, no matter how tough you are, is perhaps going to start to wear on you. So thank you.
No, this great information that you shared. This brings us back to what Dr. Wingfield shared, which is just being aware as a clinician of those subtle biases that you may just incidentally just communicate. And I don't know if Dr. Wingfield, you'd like to add anything to what Woody has shared before we move on to the next point.
Yeah, he mentioned some of the past atrocities in terms of the experimentation on Black and brown individuals, not just Black people. It's been Hispanics, and it's also been in American Indians as well. But let me tell you something. There are things and pressures, the racism, the social injustices impact communities of color every day. You think about what happened with George Floyd. And the reason why George Floyd got so much press is because of COVID, because people were still. People were home and people were watching. But the fact that we learned that Ronald Green died in 2019 by police in a similar manner, right? This is not new. And so what providers need to understand, and especially providers who are not of color, is that there are daily stressors in the lives of Black and brown people, and particularly Black men, that impact their health and well-being. And so you can imagine they're already on edge. And how you approach them, how you discuss things with them, how you actually engage with them from the first time is really important. And Woody also mentioned this importance of workforce diversity. And again, I'm grateful to Bristol Myers Squibb because they helped fund part of my education, right? So the ability to really make sure that individuals who may not have had an opportunity, I'm the first person in my family to go to college, right? It doesn't mean that Black people are stupid. We just don't have the opportunities for all of the reasons that we talked about, all of the racism that we've discussed that still is ongoing. People don't have opportunities, but workforce diversity is really important just for the reason that Woody talked about. There's an immediate comfort level, and it kind of allows individuals to really see that the person who's sitting in front of them cares for them just because of that familiarity, right? It doesn't mean that white people can't take good care of Black people, or that Black people can't take good care of white people, or any other race or ethnicity. But there is an immediate comfort level, and Woody never had to question whether or not his doctor had his best interest at heart. Unlike what we see currently in a current political system in particular, this milieu that we find ourselves in, there's a lot of fear, particularly for Black communities, and now for Asian communities, right? I mean, we have Asian communities that are being targeted. We have 6 Asian women being shot to death. I mean, this is a ridiculous thing that we have got to know about our country. I don't understand why we are the way we are, but those external pressures, those what we consider external to the healthcare system are not. People bring that into every encounter, and it's really important for us to recognize that.
Thank you, Dr. Wingfield. Amy, at this point, I would like to actually ask you the same question around medical mistrust. Woody brought that up, and I'm curious, in the Asian community, have you seen or heard or experienced, those same type of sentiments?
Yes, I have heard some of the same sentiments for many different reasons. I just want to take a step back and say that in my cancer journey, in my experience, I feel like I was very lucky in many ways because of my own creativity and craftiness. I was my own advocate. I ended up finding my own voice. I ended up, really fighting for myself, even in the writing and the blogging that I did. But so I feel very fortunate. But what I did see is that there were not a lot of Asian or Asian American women. Like when I would attend some of these survival conferences, young survival conferences, thousands of people, which is great, but I didn't see a lot of people who look like me. And that's what happened in 2013, 2014, 2015, when I would go to the gatherings year after year. I would meet other, young survivors or cancer conquerors, but I would look around and be like, where are the other Asian Americans? And when I would see them visually, I would go up to them and connect with them and be like, don't you feel like we need to get more of us? And it was a curiosity why there were so few of us. After, we gathered together and we got the word out, I think we've seen more. But I think part of it is that within the Asian community, there are so many different ethnic and racial groups. I mean, in California alone, I think that there are like 30 plus, and there's all these languages and dialects that are spoken. So I think part of it is really coming down to the level of the community and the patient and seeing what are first of all, the languages that are spoken? What are some of the community organizations out there that are really closely connected with the community, and really asking questions and listening and learning more about the culture? It would help definitely to have more providers who who speak the language, who are asking the questions, who understand what the culture is about also. But I would say short of that, as a patient wearing my patient hat, it would be nice to have maybe a navigator or an advocate or somebody in the community there if there is not that then. I still feel like there is a ways away before we reach that. And it's such a good opportunity and so critical, I think, especially as with so many different communities out there. So I feel like it's important to take a step back for providers and to listen and to ask questions, get into the community yourself and walk into the community and understand what their concerns are. So I think for the Asian community, there are also different levels of generations. You have the older generation who might not speak the language very well. You have Asian Americans like myself. And then you have another generation that might not even speak the language. So it's understanding the different pockets of the community, and also being really patient, not patience, but being patient and understanding that community.
That's great. Dr. Wingfield, the first thing that comes to my mind is the work in which you've recently done around the actionable framework on health equities. And you've called out patient navigator. And I'm curious if you could speak to that. And while you're speaking to that, with the fact that digital technology is more available now, any suggestions on how to reach these pockets of, maybe Asian communities where a patient may be in a rural location where they could perhaps tap into having a community around them without having to actually be there?
Yeah, I was thinking the same exact thing as Amy was talking. I was like, yes, because the first thing I insisted on in that publication, the Actionable Framework, which was published in the Journal of Oncology Practice back in January of 2021, so this year, was that community engagement comes first, right? So I love the idea of having navigation, but navigation really needs to begin in the community. And that's why, from my perspective, one of the programs that I developed when I was at Wake Forest and was helping to lead the cancer center there was this population health navigation program, where we brought in people who are from and of the community to help support the individuals who had the most barriers, African American, Hispanic, and rural population. So one of the things that we did realize, particularly with our rural patients, but also some of our urban families, is not everyone has access to internet. So, the digital divide is real. And Amy brought up this issue of language, right? So we know that for individuals who are non-English speaking, that sometimes using these digital solutions, if you will, may not necessarily be applied as equitably. And I think that's something that needs to be done differently. We do have interpretation lines and translator lines, et cetera, which are great. And there has to be a way to connect the two, but not every community may have availability to do that. So where there are larger pockets of communities, particularly those that are quite diverse, as she mentioned in California, I'm just struck by how many different communities there are. This is where kind of really engaging the community means also reaching out to community-based organizations, as Amy said. Find out who the people are who have the touch points in the community and see if they may be able to assist. This is not something that can be done by a single person or an organization solo. I'm just saying, I don't care if you're the largest, academic institution in the country, you have got to partner with the community. That means community members, individuals, families, but also community-based organizations to really make a difference. And that actionable framework actually pulled together experts from around the country who have been doing this type of work, who have been doing the community engagement work, but also doing the implementation of solutions that can help alleviate the barriers. And so again, I think it's a great, great document that I would point people to because there are the real solutions. And navigation is just one, and it doesn't mean nurse navigation. I bring in lay navigation. I think that's really important. Nurses can help around some of the clinical things, but sometimes it's just the social cultural barriers that can impact one's ability to really engage with the healthcare system in a way that's best for you.
Thank you. I mean, you said something earlier about diversity within the workforce. I mean, it's almost, it goes against each other. If you don't have the right, if you don't clean up your act in the house, in your own institutions around health equity, how can you even do greater work on the outside of health equity in your local community? I think those also go hand in hand. So again, if you could speak to that about the importance of making sure you clean up in-house before you try to make the change out in the community.
Ooh, you are speaking my language. So that was one of the things I said in my last institution when they were saying, well, we need to go out in the community and say, oh, your community is right at home, right? Care begins at home. And if you are a large institution, even a small institution, making sure that you are taking care of the people who are working within your institution. Look, we know that oftentimes Black and brown people have some of the lower kind of paying jobs. They're not the ones who have the salary paid jobs. These are the ones who are unfortunately working by hour. And so I've had patients who, Black patients of mine who have a cancer diagnosis and they're getting pressure from their boss. They work for the institution and they're getting pressure from their boss about being at work. I'm sorry, who's your boss? Let me pick up the phone and call them, right? So we as providers need to get engaged when we see craziness like that happen. But let me tell you, one of the things that I've been working with ASCO, the American Society of Clinical Oncologists, about for years has been this concept of workforce diversity. Now, we know, though, that it takes a decade or so to make an oncologist, right? So we don't have that kind of time. We need to fix the problem now. And so this is why taking a look internally, who's answering phones, who's at the front desk, who are your MAs, your medical assistants, who are the people that are part of the team? And that can be diverse, right? But I do think, and I love Amy's, kind of really thinking about navigation, thinking about it in a different way, making sure that we have individuals who are in the community, who are of the community, making sure that we're present in the community is really, really vital. And that can be done by any institution if you just kind of have the will to do it.
Thank you. I would like to transition slightly, still sticking on the medical mistrust and still staying with you, Dr. Wingfield, around the importance of diversifying our clinical trials. But even more important, because of the medical mistrust, how that plays into just getting access and or reaching these patients to want to involve themselves in clinical research. Can you speak to that?
Yeah, absolutely. Well, Woody talked about it, right? He mentioned the fact that, when he was thinking about clinical trials, there were other people who were probably been interested. They didn't have transportation. Again, those structural barriers, the social determinants of health. And so one of the challenges, as we know, that African Americans tend to be underrepresented in clinical trials at a ridiculous rate. There's probably only 4% minorities sometimes in some of the drugs that are being developed now in some of the clinical trials. And so it's really important to make sure that everyone has the opportunity to participate in clinical trials. And so, we also published a policy paper at ASCO a couple of years ago, I think it's 2017, where we looked at the financial toxicities associated with clinical trial participation and really outlined some of the key strategies that could be implemented to help alleviate some of the burden on the patient. The first thing is, how are we designing the clinical trials? And we see that in COVID. Again, COVID has opened our eyes. Oh, wait, we can do consents, remotely, or we don't necessarily have to get a blood draw every week and have the patient come to us. There are ways that we can structure clinical trials in a different way that alleviate burden on the patient. One of the things that I'm a huge proponent of is get patient advocates like Amy and like Woody, get them at the table when you're trying to design a clinical trial. Let them talk about what their experience. Let them review the research protocol, what you're thinking about doing, or even to be at the table before you've even created the research protocol. Hear what's important to them, right? So one of the things that I think is really important is we want people to survive cancer, but we want them to survive it well. And if we don't know what the toxicities, or we're not asking patients how they feel about their treatments or what side effects they've had, we're not going to know if they're surviving cancer well. And that's really important. And we need to make sure that every community is surviving cancer well. Not just, white men. Remember, clinical trials used to be just white men and younger white men. We even had to have this conversation around inclusion of women. So we've come a good ways, but we have a long way to go. And I must say, I mentioned that population health navigation program that I implemented at the Cancer Center. Just by kind of alleviating some of the barriers and the social cultural kind of challenges that patients face, we were able to improve clinical trial enrollment by 50% for each of those populations. So it doesn't even have to be, that, you've got to do all this education on clinical trials, because people, I think, are interested. They just have barriers, and we've got to figure out how to meet their needs.
Great point. So let's do that today. We have two patients here, so let's get the perspectives from them. Amy and Woody, I would like to take Dr. Wingfield's suggestion on getting ideas from you. What do you think, from your perspective and your experience, would be helpful to get more people like yourself involved in clinical trials? I'll start with you, Amy.
Okay, go ahead.
What would it take to get more the Asian community to participate in clinical trials? I think it would need to begin with building trust with the community. I go back to that, to the community, engaging with the organizations there, and also the healthcare providers in those communities as well that are focused on the patients there. Education and knowledge and relationships can start with everything from to face-to-face, we can get to that, meetings or materials in that language as well, I think are really important. And being a consistent force in that community, not just kind of like parachuting in and saying, we need this from the community. I don't find that works, at least for the Asian community. I think a lot of it is having to really build trust. I know that in the Asian community, and I'm speaking again at a broad brush because there's so many different groups, but I think that, everybody is open to listening to the information, but what goes on behind the scenes is whether or not they really trust the providers and understanding what is this for, and also the impact of why is this so important that they participate in these trials. If they're a survivor like myself, a cancer conqueror, I understand the importance of participating, but to get it to the community out there, and especially to different groups, you need to build trust, speak the language, have somebody come with you who then speaks the language, really, and communicate with them at a level where they get it, like where they understand, like you're also maybe a mother or grandmother or sister or a friend, like in a language that can really connect to them emotionally. Otherwise, it's hard just for them to understand why this is actually important, why they need to take the time to read up on the materials and participate. And I think the digital part is a real advantage as well, in that there are communities in more rural areas that are underserved, and they might not be able to travel to certain places. Getting them I was almost going to say 5G and broadband at the top of my mind, but I think there's a real digital divide in knowledge in communities, especially in the immigrant communities. And I think that's a critical part of it, is to make sure they have the access to use that so that they can communicate with providers as well. So yeah, that's an excellent question.
Yeah, no, what I took away from that, before I go to you, Woody, is definitely engage with the community. Materials that are going to speak to that patient population is key. Consistency, consistency, consistency is where you build trust. Being intentional impact, that's the first thing that comes to mind when I think about it. It's intentional impact to drive real change. Speak in lay language, another important component. And digital advantage. Again, I know Dr. Wingfield spoke to that other population that does not have access to digital, but for those that do, let's leverage that a little bit more. And then Woody, I would like to come to you to see if you have anything to add on that.
I'd just like to echo Amy's comments. I totally agree. What I think about is when you're coming into a community, they don't know you, right? So they're going to be distrustful. So you have to determine who are the players in that community. A lot of times it could simply start with the low-hanging fruit would just be the faith-based communities. And each family structure is different. And then when you kind of talk about people of color, Black people, we're not monolith, right? So, there's a nuance in dealing with different parts of the community. One thing that I want to talk about, and perhaps Dr. Wakefield can help me with this, but I understand that the mapping of the human genome is incomplete because it doesn't include a lot of the African diaspora. So if we had more people of color participating in clinical trials, then that could translate into having more appropriate treatment modalities for people of color. Do you have any input on that, Dr. Wakefield?
What are you going to call me out on genomics? Yes, so you're absolutely right. Probably, I think it's less than 2% of the Genome Project contains, materials from individuals from African descent. And so that is an issue when it comes to thinking about ancestry and hereditary cancers, et cetera. I think more important is making sure people can have access to the precision medicine that is available now. And we know that that's a problem, right? So, Amy talked about her, having to advocate for herself for her breast cancer. And look, I've got a mass, got to take care of this. But what Black women don't know, they oftentimes are not even getting what is currently a standard of care for an invasive breast cancer is to get Oncotype DX testing, right? So the testing, the genomic testing or other types of testing, there are several different types out there. Now part of the staging system, Black women are not getting that at the same rates. So we've got to, I'm glad that there's a whole genome-wide project. We've got to get people access to the genomic studies that actually can impact their care now, right? Mm-hmm. And yes, the research is important. And so the clinical trials, again, I agree that there has to be this trust. You've got to build it. It's really important. And I also liked Amy's suggestion of going to the providers that actually care for the individuals you're trying to reach, mm-hmm. right? They may be primary care teams. Maybe it's a nurse practitioner, PA, primary care, OBGYN, I don't care what it is, but these are individuals who, if they've built the trust in the community, have been there and have been caring for the individuals you're trying to reach, really kind of helping them to understand the importance and why we need to have their genome in that genome project, right? Why having their materials is important. There's so much mistrust, especially with, people now talking about Henrietta Lacks and all of the experimentation that was done without her consent. There's a lot of work to do. And not to say that people won't consent to it, but we need to be clear-minded. What are you going to do with that? Is it really going to change what happens to me? Not necessarily. So we've got to make sure people have access to things that are going to change what's happening to them real time as part of their cancer care and survivorship.
So talking about access, Dr. Wingfield, I'm going to pull a page from your Health Equity Actual Framework where you spoke about mobilizing healthcare and perhaps to certain settings, in order to kind of reach those who may not have that appropriate access. So can you speak to that a little bit more?
Yeah, and I just want to point out that the senior, one of our people I was able to work with on that project was actually Dr. Patty Doikos, who's at the Bristol Myers Squibb Foundation, and just want to thank her for her leadership on that. And I think BMS Foundation has done a really wonderful job at putting their money where their mouth is. So you talk about, bringing care to people. I know that they funded, for instance, a mobile unit for mammography, which in North Carolina, and those sorts of initiatives are great. But it's just one component, right? So thinking about bringing even a medicine van, if you will, into places. But even simpler than that, what Amy has been talking about is that digital presence, right? So thinking about digital health. And are there ways that we can actually utilize the landscape now, whether it be finding community partners? Because again, there are people in North Carolina, I'm thinking about my folks in western parts of North Carolina where they don't have broadband. They just don't, my phone stops working when I get to certain parts of the mountains, right? So, but is there a community partner nearby where people can come and perhaps see a physician or to see a clinician, have maybe their survivorship care happens remotely? These are the sorts of things that I think I would love to see leverage, and that's where we can bring care to patients and we can bring clinical trials to patients by utilizing the community centers. Remember, most of oncology care happens in the community, about 80% of it does. And if we can get clinical trials there, it will make access to clinical trials a lot better and easier.
Great, thank you so much. Amy, I know we're getting close to time to transition to our Q&A portion of our program, but there is a question I want to ask because you spoke about resources. And I'm curious if you happen to have any resources in mind that you feel would be beneficial for patients that you could share with healthcare providers listening today to just help advance the care in which they receive.
Well, the resources I think that are truly helpful, at least have been helpful to me as a patient and as a survivor have been online. A lot of them, actually. I mean, the outlet that I eventually found to connecting with other young survivors and also Asian Americans was actually through groups such as, the Young Survival Coalition and also certain groups on the social media platforms as well. And also I would say that there are groups actually within Asian American communities now, like there is the National Asian American, breast cancer group that holds, actually they do a lot of the fundraising and actually a lot of the awareness online. So I would say in terms of, but there's still a lot lacking. I'm just going to be really frank about it. Actually, there's not enough. We really need more. We need a community online. We need communities offline. So there's a Chinese word for crisis is actually a mix of the characters for danger and opportunity. So I like to focus on that. And I say that although we are not there yet, there's such a big opportunity to build that. So I've been thinking, even as myself, as an advocate, geez, I would love to connect with providers and people in the community and other survivors to create that hub, where that information and where people have an opportunity to connect with one another. But so the answer is, while I found certain groups for myself, there is not enough of a wide group out there yet and a place for people to go.
Thank you, Amy. Woody, did you have anything to add before we transition to the next section?
Let's see. I just wanted to say that, I've totally enjoyed the conversation. And I always think about Dr. Maya Angelou, who says that when we know better, we do better. So what our conversation today has been about is highlighting a lot of the challenges and opportunities as we move forward. So I think that we can all be mosquitoes, and we could be that little annoyance to advocate for better health care for all people.
Thank you so much. Go ahead, Dr. Winfield.
Can I just mention the resources too? I do want to mention that there are a lot of resources online, and I know Amy mentioned a few that are particular to her community. But I want to make sure that people know that you can go to cancer.net, which is an amazing resource that actually lists other resources. So I think we've talked about the fact that people's social circumstances, their finances oftentimes gets in the way. Cancer Support Community provides funding for patients during the course of therapy. There are financial programs that will help support individuals during the course of therapy, to potentially pay and have copay assist, and some of the pharmaceutical companies will do that. But we're also talking about survivorship, and it's what happens afterward. There's a lot of times a lot of support around patients during the course of treatment, and then afterward, sometimes they feel left to their own. And this is where the advocacy groups come in. There are wonderful breast cancer groups. There's wonderful groups around colorectal cancer, the Blue Hat Foundation. There's wonderful groups around prostate cancer, particularly for Black men, the Prostate Health Education Network. But it does require sometimes some digging. And this is where it would be great to have a resource that can help pull us together. I would again suggest cancer.net. There are lots of other organizations that they list, Live Strong, et cetera, and other kind of support groups. But I do think kind of making sure that providers know, and whoever's listening knows where they can go now to look for some of these resources is really important. So thank you.
And I can tell you where to start right now. You can start with our BMS virtual booth here at the conference. We have a lot of great survivorship information that I find may be able to help clinical practices at the point of care. So if you can, after the conclusion of this program, please do start there. All right, great first half, and thank you so much to everyone for being so candid and being informative and sharing such great insights and solutions on how we can meaningfully and intentionally tackle this problem. So now we're going to transition to our Q&A, and as the questions are coming in, again, I just want to encourage and remind everyone who's listening in, please do submit your questions simply by going to the chat function on the right-hand side, submit your questions, and then I'll try to get to your question before the end of our Q&A portion. Dr. Wingfield, we already had a question that came in, and this one talks about preventative care and screening. So in particular, can you talk about the access to preventative care and screening and the disadvantages that the underserved communities encounter that ultimately leads to poor health outcomes?
Yeah, it's a great question. And, you know, I didn't mention this. Normally I do talk about the cancer continuum, right? And I think we've got to really think about access to care along the entire continuum. That includes prevention, that includes screening, detection, treatment. And I put clinical trials as a part of treatment. Unfortunately, sometimes providers think of it something as extra. No, the clinical trial is should be a part of standard cancer care. And so when we think about the issues related to prevention and even screening, there are so many barriers. I mean, we talked about some of the structural barriers, the structural racism that actually impacts one's ability to live well. And Woody mentioned David Williams. I love Dr. David Williams. If you have not seen the documentary called Unnatural Causes that's on PBS, please do so. It talks about the fact that wealth equals health. Your zip code matters. They go through 4 different cities and they look at people's status. It doesn't matter if you're white, black, Asian, Hispanic, it doesn't matter. Zip code impacts your access to health and well-being. And some of it's related to the stresses that you find yourselves in. Some of it's related to those microaggressions, and sometimes it happens more frequently with one community over another. And so this is where prevention comes in, right? We know that one of the most modifiable risk factors is tobacco, right? So tobacco use. And so how do we kind of encourage people who may be stressed, who are looking for ways to help calm their nerves, right? Alcohol, cigarettes, etc. That's one thing. The other thing is food. And obesity is a huge epidemic in the Black and brown community. So Blacks and Hispanics have some of the fastest growing rates of obesity. In fact, when you look at African American population, 70% of the African American community is obese or overweight. And that is a modifiable risk factor for cancer, and people don't realize it. So there's a lot of education that needs to be done. That in and of itself is a barrier. Lack of knowledge is a huge barrier, and it's one that we need to do better as a community of providers and as you know, institutions and organizations who claim to be interested in these topics, is to really provide opportunities for education. But we also have to figure out how to reduce some of these structural barriers, and that includes kind of dealing with the policy, right? So we've got to deal with what's happening, boots on the ground. That requires some legislative action. And so I think people are always afraid that, you know, if one community gets something, that means it's going to take away from another. No, that's not it. Not here in the United States. Not when, you know, more than 90% of the United States population makes less money than the top 1%. We've got a problem here in this country where there's a lack of equity. And that's all it is. It's not equality. We're not asking for equality. We want equity. And there's a big difference.
Thank you, Dr. Wingfield. We also have another interesting question that came in, and this one I'm going to direct to you, Woody. This one is around the disproportionately effects of Black men on what could be done more around helping them become long-term cancer survivors.
I would say information is key, and I think that that's echoed throughout our conversation today. Also, the support systems. You know, if you are married, normally the spouse is a good person to sort of push you to, when you're feeling something, to go get it checked. So it's just about, what your support system is. I'm distressed about anyone who has a cancer challenge, but particularly when it comes to Black men, we have to advocate for our own care, and we have to understand that early detection really is the key to survival. Because if we catch things early, we have a greater probability for success in our treatment and overcoming the cancer challenge.
Laura, can I also just make a comment on it? Because I think one of the issues related to outcomes, particularly cancer outcomes, is other comorbid conditions. And so oftentimes what happens is, Black men may have cardiovascular disease or diabetes or hypertension, other things that may not have necessarily been diagnosed or treated. And to Woody's point, usually if they're married, their health status is a little bit better because they have their wife or their spouse who's beating them over the head to kind of go and get some of these things checked. But I think there needs to be a focus on holistic well-being, and not just on a diagnosis, not just on cancer. And so again, for some people, when they get a cancer diagnosis, and this is across the board, the cancer diagnosis may be the first time that individual is participating or experiencing the healthcare system. That may be the first time them being diagnosed with cancer, right? Lump in the breast. Oh my goodness. Wow, I got to go to the doctor. Dang, and they may end up in the urgent care or whatever, but then they're put into the healthcare system. So as providers, it's really important, again, to look at the whole person. Don't just look at their cancer, but say, what are the other things? I mean, I remember having a woman come in to see me whose blood glucose was 600. I was like, no, like we're about to fix this right now, right? Even though I'm a radiation oncologist. I mean, these are the sorts of things. We cannot just focus on one thing. We really have to look at the entire people. And I think that particularly for Black men, particularly with all the stresses, their inability to access healthcare for a variety of different reasons, that also plays into outcomes.
Mm-hmm.
Great point. Again, back to treat the patient, not the disease. Another point that I wanted to make, just to kind of chime into this very question, is there's a lot of great community work being done at barbershops. There's a lot of great work being done at, religious institutions, that could really be leveraged by those institutions that are within those areas to do maybe free health screenings, maybe health fairs. So there's other opportunities for the community to tap into those entities in order to reach Black men. So keep the questions coming. A lot of great questions that are coming in so far. And actually, for this next question, Amy, I'm going to come your way. From your perspective, what is working and what needs improvement with respect to cancer survivorship care? And what initiatives supporting survivorship care do you find to be most impactful? And anyone could take this question, but I'll start with you, Amy.
Cancer survivorship care, it's really multifaceted, and I think a message that I was trying to get across is that it's much more than the part that what I call the more technical parts of the care, like addressing the cancer and the disease itself is already, I think, stressful enough for anybody. From in my own case, it's true. I had never really entered the healthcare system before discovering this lump. And so having to navigate that just as the patient and addressing the lumpectomy, the radiation, that was already one level. But the other level of stress was the loneliness and sort of the lack of feeling like there was a place or somebody or a community I could talk to about this. I think it's so important to have that. And as part of physical well-being, I mean, there is a connection between one's emotional, mental health, and also your recovery. Two are closely connected. So I think I eventually found my own network of friends and fellow survivors and quote unquote angels that I could talk to, pick up the phone with, and I could just share my story with. But not having that, I felt was just like another level of a stressor beyond just recovering. So I think that is so important to take that into account, having that as well. And also, I would say that the food and health and wellness is a critical part of it. Dr. Winkfield talked extensively about that, but I think making that fun. I've actually been lucky enough to attend, like, we had, I think it was a cook.
Your diagnosis, what's going to come forward. And I don't hear a lot of talk about, the treatment plans, even what you're getting, that you can develop comorbidities from your treatment. So I think it's important to understand what might be coming down the road for you after your treatment.
Dr. Wingfield, I'm coming to you.
Yes. So all very good points. And I think, a lot of times people think about survivorship as, well, what happens after treatment? And I actually don't divide it that way. I actually say once a person has a cancer diagnosis, they are in survival mode, right? So we need to start thinking about all those things that Amy and Woody just said, right? Not only just what is the treatment course, but what are the supports we're going to put around people during the course of therapy. But I think one of the challenges that I see oftentimes is this, once people have gone through their cancer treatment, is that they oftentimes get dropped off, right? And this is really critical for patients who are underserved, who may be under-resourced. So Medicaid patients in particular, some of them may get emergency Medicaid, during the course of treatment. And that insurance will last during the course of treatment. And then afterwards, they have no health insurance. So again, what are we telling people in this country? Are we telling them that they're not important enough because they're poor? Well, we've set up that structure of poverty here in this country, and we've got to do a lot of things about that. And Amy brought up this whole concept of thinking about, adolescent young adults, and that's one of the most underserved communities. So we think about adolescent young adults as age 15 to 39, and think about all the changes that are happening as a teen kind of becomes a young adult, right? They're finishing up high school, they might be going to college or graduating from college, or getting married or developing, having a family, all of those transitions, careers, etc. And you have all this stuff going on, and then boom, you got cancer on top of it. I mean, these are all things these are really important mental health issues that we really need to focus on, because, to Woody's point, yes, the treatments may have side effects, but some of the side effects are actually emotional. Those emotional scars, and that can impact one's long-term, outcomes, especially if they don't have support systems wrapped around them. And it can be hard to talk about cancer. It can be hard to talk about emotionally what you're going through. But this is where, and I'll say sometimes to my patients, I just like for you to talk with this social worker. You might only meet with them one time, right? But to have someone who's not a family member, someone that you can actually just have a conversation with and be able to talk about all things that are troubling you can really go a long way. There are other aspects of survivorship care as well. I think it's important for providers, oncology providers, to really have really good communication with primary care providers and primary care teams. Really critical to make sure that transition happens. Oftentimes oncology care is a black box, and then we're like, okay, well, now go back to your primary care team. And that's not the way it should be. There needs to be robust communication and really kind of talking about the things that have happened, so that when Woody says, oh my goodness, this patient went into this room and they didn't understand what the physician said, but the oncologist said, because I've had patients sit there go like this and they act like they heard everything that you said, right? But then they don't know. Having another provider who is a trusted individual who cares for that person in the loop really helps. It goes a long way.
So there's a question, and I can actually ask any of you to chime in on this one. It kind of touches on what you just ended with, Dr. Wingfield. It's around, if you're in an institution that does not have enough diverse staff, how do you better approach and reach those diverse patients in an appropriate way?
I think Amy would answer that one really well.
Feel free, Amy.
Amy's talking about it, right?
If you don't have a diverse staff, how do you still address, the patient population? I mean, I think it's on different levels. If you don't have a diverse staff, especially those who are providers or the key decision-making levels, I think I would hope that there would be some changes within that, and maybe looking at, recruiting and opportunities to maybe partner or collaborate with some of the community healthcare providers. Then maybe there are certain programs that can be started, or even at another level, workshops, community events, workshop series that can address that population. Maybe building those relationships from there and moving on. And I think it's a real good opportunity now, because there's virtual. You could do it by Zoom, and also maybe eventually have it hybrid. So you can even reach a more extended audience that way as well. But I do think hopefully the organization and institution would consider bringing in people who speak the language, people who know what questions to ask that community, take the time to get to know that community better. And I realize that it does take a lot of time and persistence, but I think it's critical to build that foundation if you're going to have a long-term and big picture sort of vision of where this is going to be, and not just, like I said, parachute in. But I see it as a really good opportunity that doesn't exist right now. And it's so necessary to have that, because the communities that are underserved, I'll just speak about the Asian community. There are different levels of different kinds of groups, but they play such an important role in our society. A lot of the communities are working in shift work, and whether they be restaurants, a service industry, salons, they are critical to everyday, to our economy, everyday life, important part of the society. So I think it's just a part of our fabric. It's necessary, and it's not just an alternative.
Yeah. And I think that partnering with community organizations is key, because, look, there might not be a bilingual, bicultural, nurse or whatever that's available in your community. I can tell you that, but there are organizations out there that might support them. So one of the things that I've been doing as a provider is I look for people who are willing, who are interested in giving back. I have patients all the time like, I just want to do something. And this was really important for me in the rural community, and trying to find rural Black patients or Black individuals to help support Blacks in rural communities was tough, because there aren't that many Blacks in rural communities, but they have needs too. So I actually found one of my patients who lived in a rural community, and she was actually willing to drive patients back and forth from the rural community. That was her way of giving back. And so sometimes there's a way to actually leverage the patients themselves who have gone through treatment or maybe undergoing treatment, to really help them create community. And I did the same thing when I was at Mass General Hospital. I had two patients that came to me simultaneously. It was very interesting. A Black woman with breast cancer, Black man with prostate cancer, said, we can't find a support group for us. And I'm like, well, would you like to create one? Right? And then empower them to go ahead and create that, provide the space or whatever it is, or, as Amy pointed out, we can, Zoom is beautiful now. And so really leveraging the people who walk through our door. So sometimes we might not have a provider, or we might have a nurse, or we might not have an immediate staff member who looks like a person, or a patient community. But we certainly can find somebody in the community, whether it be a community organization or individual that we may have treated, who would be willing to step up and help out.
I just wanted to add that I think that advocacy is important, that, sometimes we just got to step up. I happen to live in a community that's about 86% white and maybe 1% African-American, right? So I just take it upon myself as to force myself into the limelight, to be on the cancer community committee, and then on the cancer committee at the local medical center. So because, what happens is that, I bring a different perspective, right? And if we're at the table, then we can affect change. So I think that as volunteers and advocates, that we gotta, sometimes it's hard, but we gotta get in there and get on the front line and just, as I said, be that mosquito, just constantly annoy until we affect change.
Yeah. And to
like
the person who asked the question,
get in there.
Yes, and the person who asked the question, there are people just like Woody who are willing. So again, while you might not have staff who can help support, there are individuals who are of those communities that you can tap into.
And even to take it a step further, maybe that's an initiative that could be created. Ask the question, are you willing to advocate on behalf of other patients that come into this clinic? And then create your own system of advocacy. I mean, that's quite simple. It's a simple question. You get their information, the number, and create your own system. So that's another potential solution to create something more locally for those who are not able to kind of venture far away.
Can I
All
add
right.
to that really briefly, Laura, as well? Oh,
Absolutely.
can I add to that really quickly? I also think it's explaining in a layman's language what advocate might mean, because like I know that after I went through my treatment, somebody's like, you could be our advocate. And I was like, oh, I'm really shy. I don't know what you're talking about. So in my mind, an advocate was somebody petitioning on the streets or something. And I think it just sending the message that it could be everything from sharing something on your social media feed, or maybe even calling somebody, or just making sure that you don't need to be necessarily trained in this. Everything that you contribute is really important. So maybe explaining what advocate means.
Mm-hmm. Yeah, I agree with that, Amy. I think it's really important that if you are going to engage patients in assisting others, that there definitely needs to be a framework. So it's not just kind of, and everyone can't do it, right? There are some people who, you might say, you want to make sure the information that's being delivered is accurate, number one, right? And that it's not necessarily layered in that person's, negative experiences, et cetera. So I think there is some opportunity to do some education around what advocacy is and what the extent of that is for your particular practice, if it's something you want to develop on your own.
Thank you everyone for chiming in on that. I think there was a lot of great pearls that were resonated during that response. Now, I know we're close to time, but talking about training, we had another very important question come in, and we actually just combined them just to make it simple. So what are your thoughts and suggestions on clinical training that can reflect suggestions from your framework? I'm assuming this is to you, Dr. Wingfield, on how can medical education improve health outcomes for all of our patients in the realm of health equity?
So I think, there has to be work done on the individual and institutional level, right? Everybody wants to, okay, I'm ready now. Let me go ahead and somebody teach me. No, we need to do our own learning, okay? There's a lot of information out there. Let me point you first in the direction of understanding social determinants of health. Because for those of us who have been privileged and who may not understand what all of that is, I think it's important to start there. ASCO has a series that's on YouTube now that actually is all on social determinants of health. They're up to episode 5. I would say go to YouTube. It's called ASCO Cancer, and take a look at that. That's one kind of way. In the framework, we've been very intentional about providing references to the best practices and things that work. So again, I think that's another way, that is understanding what is going to work for your community. Because trust me, not everything is going to work the same in every community. I've worked in Boston. I've worked in Winston-Salem, North Carolina. I'm now in Nashville. And the techniques and the things that are implemented must change depending on the community I'm trying to reach out to. So what I worry is that when people ask those types of questions, that they're looking for a quick, simple checkbox. How can I educate myself? Let me do this now. And that's not what it is. Even implicit bias training, people are, I already did that. Checkbox. No. It's a process. It's an ongoing process to maintain your culture of humility. So I think people have to understand the context, understand what this country has allowed to happen around the social determinants of health. That's a beginning. And there are some courses there, even ASCO University has some things. I mean, you mentioned, Laura, Bristol Squibb has may have some opportunities. I think it's really important. There's a lot of work that has already been done that people can look to. Let me just point you to one more paper that I've written, came out last year. It's called Why Racial Justice Matters in Radiation Oncology. Now, it's specific to radiation oncology, but the principles that are outlined there can be applied broadly across any academic institution and frankly, any institution. There are 2 different programs that are there. One is for the individual to do the work that needs to be done around understanding racial injustice. And then the other is at the institutional level. So what Amy had talked about, take a look inside, what's going on in your organization. That framework is there. And again, all the references that are in there, there's work that needs to be done. People are not going to just hand it to you. Not anymore. I think those of us who have been in this work, we're tired of telling people how to act. We're tired of telling people how to behave. You got to do the work to say, why are things the way they are? And how have I contributed to that personally, even though you might not be racist? How have I contributed to the racist, society? And then what are the things that I personally need to do, or what does my institution or my organization have to do to help be part of the change that's required?
Thank you. And I like the fact that you touched on that about we need to first identify within our own self how we're coming forward at the point of treating patients. So I think that's an important part of the change process. as well as the consistency of evaluating your policy and procedures. Making sure that they do work, make sure the outcome and the impact is exactly what the goal is meant to achieve. So thank you for kind of touching on that, Dr. Wingfield. So we're coming close to time, but I do want to ask one more question based off of what's coming in. And this one is back at you, Dr. Wingfield. Can you tell us your role in Meharry Vanderbilt and what type of programs are in place to address health inequity, excuse me?
Yeah. So Meharry Medical College is one of 4 historically Black institutions that actually have medical schools and centers associated with them, right? There's only 4 in the United States. And they've been very instrumental not only in producing a tremendous number of Black doctors, physicians, but also dentists. So Meharry Medical College has a school of dentistry, and also basic science researchers. So they have also graduate programming. So the Meharry Vanderbilt Alliance has been around for 20 years, and it's really a liaison, a partnership between that HBCU and Vanderbilt, which is a predominantly white institution. Both have strengths, right? Both have capacity. And so how do we leverage the capacity of both of those organizations to really work on improving the health and well-being of our communities? And so, I'm the 3rd executive director. I just started in November of last year, and I really am all about community engagement. And that's what the MVA is going to be about. And doing engagement for engagement's sake. There was a huge emphasis on research in the past, and I still think that we will potentially be able to do some research that helps to understand how to engage communities, right? So again, people want to have it in a paper, they want to see it in a publication. There are best practices out there, but unless, people see it in an article, it's not real. So, we will be doing some research around that, but it's really about kind of thinking about ways to engage communities. So one of the important programs that we have is an interprofessional education program, where what we do is we take students from social work, from public health, from medical school, from dentistry, and from different organizations. We have 5 different institutions, including Belmont, Lipscomb, Meharry, Vanderbilt. We take students who are in these different interprofessional education groups, and we pair them with a community partner. And we ask the community partner, is there an issue that you would like to be focused on that you might not have the time or to actually put attention to? And so we've worked with public housing, for instance, and one of the projects that recently came out was they felt like their Black teens, women, had some issues with self-esteem. So we had our interprofessional students kind of come up with a suggestion, some programs. They got to know the community partner, and they actually came up with a proposal of ways that they can help to improve the self-esteem of young Black women that were living in those communities. And what's fascinating is that we do this with different types of community partners, and we allow the community partner to say what their needs are. And then we leverage the ability of these students to actually engage in a different level, in a different way. They have oversight by instructors. But what's amazing, this is what true community engagement is, right? Not going in and popping in and doing research, and doing that helicopter stuff because you need something. It's about what does the community need, and can we help them right where they are?
So I know we're almost at time, but I do have just one more question if you answer in 30 seconds or less. Curriculum around trying to reach our young clinicians. Is there anything that you can point, this particular question, whoever's asking this question, can you point them to the right direction on how to incorporate something in the curriculum for young MDs or HCPs that are up and coming?
Yeah, I think, again, there's a lot of resources. I would check ASCO University, but there's also work that's being done at Harvard. When I was on faculty at Harvard, I was part of the health disparities group there. And we did some curriculum redesign. It has to start with the people who are actually teaching the students. It can't just be, let's have the young people know this. No, because who's modeling the behavior? It's the people who are in practice. Yeah. So from my perspective, I think it's great to kind of try to put something in a curriculum, but I think you need to actually train the trainers first. And that's what we did at Harvard. We actually did a lot of education work with the faculty because they're the ones who are going to be the ones who are going to demonstrate the behaviors.
Awesome. Well, thank you again. Huge thank you to our panelists. This has been an excellent discussion, hopefully one of many to come. We are at time, and I would like to thank you for sharing your perspective and potential solutions. This helps us better understand the work that needs to be done in health equity. With that being said, I do want to encourage all of you to continue to take some of these pearls and bring it back to your institutions to drive change. This is the time better than ever to be able to make that happen. We have tons of resources, as Dr. Wingfield has alluded to. We have our ASCO booth that you can go and try to access clinical trial information, survivorship information, and anything that you feel will be helpful for your practice. Again, thank you for the opportunity. Thank you for joining today. Enjoy the rest of the conference.